All right, all yours.
Thanks. So good afternoon, everyone. My name is Sandy Hobbs, and I will be doing the facilitating part of the meeting today. And then another coworker of mine will be helping that as well. And then there's some other pieces that Marisha will be doing. So I think it's the three of us for this particular session. And then this is really just setting the stage for the upcoming meetings and ensuring that we're all on board and ready to do the work in designing as well as giving our recommendations for the DUI process. So that's what this meeting really is about today. And so we'll go ahead and get started. So welcome to all of you guys. And I would also, let's just go down the list here of the people and then have you guys introduce yourself. And I'd kind of like to know also what your part is while you're here, if there's a certain part that you have in this meeting as well. So let's see. Do you have the agenda, Marisha, where we can just put the names up there? That might be easier. And then we can just go down the list and everyone can introduce themselves.
Yeah, let me bring that up really quick.
Great.
Sorry, I should have had that ready to go.
Oh, that's okay.
Hey, Marisha, just to let you know, Debbie Ruiz says she's on hold and she can't get through. So she called in.
Okay, thank you. I will reach out to her on email. Let me get the agenda up. Okay, can folks see my screen?
Yeah, can you make it a little bit larger for us? I mean, like, I can't read it. Thank you.
Is that better?
Yes.
Okay.
Okay, let's go ahead and start. Is Kate on the line? She here?
I'm here.
Oh, okay. So we'll just start and go down the line and then we'll do the next group and the next group. And if you just would like to introduce yourself would be awesome.
Okay, my name is Kate Duke. I'm the Programs Manager for Mothers Against Drunk Driving and the Vice Chair of the Governor's Advisory Committee on DUII.
Is Chris on the line?
Good afternoon, everybody. My name is Chris Wigg, and I work at Emergence Addiction and Behavioral Therapies in Eugene, Oregon, and that we provide DUII services to folks in Lane and Lynn counties, and that my job at Emergence is I'm the program director for the treatment court program. So I'm excited to talk about that interface between the court and treatment. That's my favorite thing to talk about. So if you let me go, you'll have to cut me off. Thanks.
Dan, is there a Dan on the line?
I don't believe Dan's able to join us today.
Okay. What about Deborah?
She is who I'm reaching out to try to get connected.
Okay. And then we have, is this an Eric? Do we have Eric on the line?
I know Judge Bergstrom was coming back from a conference and he was going to join us if he was able, but I don't see him as joining yet.
Okay. So he goes by Judge Bergstrom then?
Judge Bergstrom,
okay.
Yes.
Okay, great. Heather.
She's on vacation this week.
Is Jose on the line?
Yes, this is Jose, and I'm Jose Garcia with the New Horizon program. I'm the program director, and this is for Eastern Oregon. I'm also the chair of the Hispanic Advisory Committee at City Hall in Hermiston. So thank you.
Joseph?
Yes, I'm Joseph Martina. I work at Tillamook Family Counseling Center in Tillamook, Oregon, and I am kind of the point person for DUIs and do most of the DUII treatment here.
I think Deborah was just able to join by phone.
Yeah, Deborah doesn't read her memos very clearly.
It's okay. Do you want to introduce yourself real quick?
Yeah, sure. Deborah Ruiz, ADA Support Learning Evaluator from Multnomah County Circuit Court.
Justin, you're next.
My name is Justin Nielsen. I'm owner and executive director of Oregon Recovery Behavioral Health. We have locations in Kaiser and in Salem, and the majority of our work is DUIs. I'm also on this committee representing the Governor's Advisory Council for the DUI Task Force.
Thank you. Not sure how you say, is it Lori? Is that how you say that, or am I saying that wrong?
Lori Logger, and I am the owner executive director of Reconnection Counseling in Lincoln and Lane County, and we offer DUII treatment for both Lincoln and Lane County.
Thank you. Lisa.
Hi, my name is Lisa DeValbaker, and I work at Transformations Outpatient Program in Klamath Falls, Oregon. We're trying to meet the block, and we are, just getting better at this DUI stuff and learning a lot. Thank you.
Okay, we hear some background noise, so please mute yourself unless you're talking. Thank you. And then Mark.
Yeah, my name is Mark Patterson, and the long title is I'm representing Department of Corrections within the Community Corrections Division, and the unit is Interstate Compact. So I'm representing Community Corrections and then Interstate Compact, which supervises offenders both incoming and outgoing the state of Oregon.
Marisha.
Hi, I'm Marisha Elkins. I'm the DUII Services Coordinator with the Oregon Health Authority Health Systems Division. I've been in this role for a little over 5 years now, but have been with the Health Systems Division, and prior to that, Addictions and Mental Health for a little over 10 years now.
Mary.
Hi, I'm Mary Garcia. I'm an Operations and Policy Coordinator at DMV Driver Programs. I oversee the DUI and implied consent programs at DMV, and that includes the alcohol and drug treatment component of reinstatements to obtain driving privileges. I'm also the liaison for the Governor's Advisory Committee, the DMV liaison.
Thank you. Matt, are you on the line?
I am. I'm here. Good afternoon. I'm Matt Conrad. I'm a program director at LifeWorks Northwest. We run DUI treatment services in the Tri-County area. We're one of the largest DUI outpatient treatment providers in the state and in the Tri-County area, and I'm happy to be here.
Thank you. Rick, are you on the line? Is Rick not here today, Marisha?
I hadn't heard that he wasn't going to be here, so he might be joining us late.
Okay. Or he might be doing the same thing I did, was that I used the information thinking it was going to be the same information to call in from last month.
I'll send it to him. I'll send him an email just in case. Thanks.
Okay. Thank you.
That's good to know. Thank you for letting us know that too. And then Robert, or do you go by Robbie? Is that right?
Either or. My name is Robert Noche. I'm from Multnomah County. I'm on their Multnomah County Behavioral Health Advisory Board. I'm on the executive committee. Also on lots of county and state advisory boards too.
Thank you. Sergeant Mike Pelkey? Are you on the line?
I have not seen him join yet.
Okay. Is there a Tammy?
Yes, hi. My name is Tammy Hooper and I work for NARA Northwest in the Portland metro area. And I serve the adult addictions population. I'm the outpatient manager and we're a DUI services provider.
Thank you. Tanya.
Hi, I'm Tanya Cochran. I'm the Director of Quality Research Associates. We are an ADIS agency for the Lane County Courts.
Thank you. And is there a Winona?
Hi, yes, Tatzalach. That means good afternoon in Cayuse. I am a member of the Confederated Tribes of the Umatilla Indian Reservation. I work for and live on the reservation. I am the DUII service provider, and I also provide culturally specific recovery services. I'm located in Pendleton, Oregon.
Thank you. Who have I missed, Marisha, other than I also need to get Carrie and probably Nicole? Is there anybody else that I missed on this list before I call on them? If you're talking,
Sorry, I'm muted. We've covered all of the members. Yes, we do have Nicole and Carrie, and then we also have Clarice, who's here, and to introduce herself as well.
Well, let's go with Clarice, and then we'll get Carrie and then Nicole.
So just as a brief intro to Clarice, so we are really happy to be able to have a facilitator come and work with us in the upcoming meetings to process through the issues and barriers that we've identified and develop recommendations. So Clarice comes highly recommended from folks that we've worked with, and I'm really excited to get to work with her on this project. So I will turn it over to her, and she can introduce herself and give you a little background on the work she does and that sort of thing. So.
Thanks. Took me a minute to figure out how to unmute myself. All right. So thanks for having me, even though you don't even know that yet. So my name is Clarice Bailey. Please call me Clarice. I come to you as a replant in Oregon. I'm back to Portland after being on the East Coast doing work for about 20 years. My pronouns are they and them. My race and ethnicity, I'm Black and Indigenous, and we are working to sort through what that means from my grandparents and my great-grandparents. My work is in organization development, human services. I teach graduate school at St. Joseph's University in Philadelphia, which is at this point an online graduate program. I teach organization, culture, and change. I do all kinds of human service consulting, education, mental health, child welfare, the justice system. And I've been around this work for a long time. So you'll get to know me, I'll get to know you. I'm honored to be here. Thanks, Marisha, for inviting me to speak.
Thank you. And yes, we're very excited about you joining us. Nicole, do you want to go next?
Hey, everyone. Thank you so much for being here. I'm Nicole Corbin. I am one of the managers in the Office of Behavioral Health at the Health Systems Division at OHA. I manage the Addiction Treatment Recovery and Prevention Services Unit, and I'm really very pleased to have so many smart and dedicated people here to work on doing some wonderful problem solving. So thanks so much.
Carrie Johnson.
Hi, good afternoon, everyone. My name is Carrie Johnson, and I am a business implementation analyst, and I work for Health Systems Division in the Governance and Process Improvement Unit. I've been in this role the last about 4.5, almost 5 years, and I've been with the state for 11 years now.
Thank you, Carrie. And then my name is Sandy Hobbs. I mentioned that in the very beginning part. I will be just helping with the planning of this. I actually work with Carrie in the Governance Process Improvement Unit. I've worked with the state for about 12 years. And as far as doing work very similar to what you guys are doing, different subjects at times, I've been doing it, I don't know, like 20 years. So I did it before I started working for the state and then continued on with the state as well. So that's who I am. And then let's go ahead and get into our agenda items. I think our next item is the public comment, and that's Marisha's going to talk a moment about that, I think.
Yeah, so we didn't have any written public comment submitted, and no one signed up for verbal comment this week, but we will continue to offer this at the beginning of each meeting for folks who do wish to provide comment in the future. So we're already ahead of schedule, so we might get done early today.
Yeah, and along with getting done early today, which I'm sure that we will, just remember this meeting is just a really setting the stage, getting to know each other, and then the next session, which will be in September, will really be jumping into a lot more of the detail work. This one is just understanding what we're here all doing, and like I said, getting to know each other and getting some agreement on the problem that we're here to solve and the recommendations that will be given. So Carrie will be giving a little bit more of that in a few minutes. But I'd like to start with a little bit of ground rules. I think it's important for us just to really be able to gather some ground rules of what's important to each of us as we get started in this work. And so there's just a few that I like to start with, and then I'd like to hear from all of you. And Marisha, maybe right underneath ground rules there, you could type some of those out so we don't lose those. So one of them that I think is important is that we keep in mind that we can if. So what I mean by that is we want to be sure that no one feels like if they give a recommendation or their thoughts that somebody says, nope, can't do it, because that kind of shuts people down. So we want to be able to say, well, we can if, and think more in that positive way and not just shut it down. And it's really interesting what ideas can come from ideas that are we can if. I've been amazed through the years that I've done this to see all the things and that have come just out of that one statement. So that's why I always ask that we keep that in mind as we go forward. The other thing is I want people to feel free to share. If you feel free to share and there's no wrong answers, then you really get to know that you're getting heard and that we're here as a team to work things through and in developing and giving these recommendations for the new DUII process. So think about that too, that we want to just be able to have the ability to feel free to share. The next one, can you believe I have these that I like on my list? Sorry about that. The other one is consensus. You may not always agree with, but you have to be able to support the majority. So keep in mind that people are going to give their ideas, but in the end, we need to be able to come to an agreement. So consensus is always, not always, does it always go your way, but that we need to keep in mind that we need to be able to agree with the majority. And then as we go through this process, we will be having a parking lot too, that we will be adding things to. This is just because not always things that we have in mind or that we're sharing has to do with the problem that we're here to solve, but might be something that might come in later or something that we want to address later on. So keep that in mind as well. And then just keep an open mind as we're designing and giving those recommendations for the future. So, and that is what I have on my list. So now I want to hear from you guys as to what you would put on this list. I gave you 5.
I got one. This is Jose Garcia. To be committed.
Thank you. That's a great one.
This is Robert. I won't see this a problem, but just in case, I believe in principle over personality.
I'm going to have to keep some of these for future groups that I work with. I like some of these that you guys are coming up with. So any other ones?
Yeah, I have a thought, and it dovetails on number 5, which is keep an open mind. It's just, we're here to maybe innovate a bit, and so maybe with an eye towards innovation. And just because something has not worked in the past or something feels like it might not work tomorrow, doesn't mean that it's a bad idea or that we shouldn't try it. So innovate and don't be afraid to suggest something even if it hasn't worked before.
I really like that one. So thank you for sharing that. That's important, that a lot of times that people will feel, well, we've tried this before and it didn't work, so got to throw it out, when sometimes it didn't work because, and we need to figure out how we're going to solve that problem. So that's excellent. Thank you for sharing that.
Hi, this is Kate with MAD. I have a suggestion. I don't know if you want to put it on the list or not, but in other groups that I've been a part of, one of the things that has been a problem is going off topic. You kind of get talking, and pretty soon it develops into a sideline, and then you got to wrap everybody around and come back to the point. So maybe be respectful of the time and stay on point.
Thank you, Kate. That's really good. These are excellent that you guys are all sharing. So thank you. Chris,
sorry, I just want to get a quick clarification from Kate. Kate, can I say stay on point and stay in scope? Would that capture it?
Yeah. Clearly we're going to be, talking about innovative ideas and trying to come up with ideas, but it's really easy to, start with one thing and then you end up with, straying off into an entirely different subject or issue. So I would just, trying to stay on point and within scope is a great way of putting it.
Okay, I'm totally guilty of that.
Chris, did you have one to share?
Sure. So my favorite group norm for groups like this is called step up, step back. And it is that if you are a person who is like me and likes to talk all of the time and has something to say about every single item, maybe take a second thought about what you want to say, if that really going to contribute to the point of what we're talking about. And if so, then share it. But if not, maybe give the opportunity for another person who maybe doesn't speak up as often to step up and to share more often. And then if you're that other kind of person and you're thinking about, well, I don't, maybe what I have will add value. You're on this committee because what you have to say does add value, and that we're counting on you to step up. So step up, step back.
Oh my goodness, that's excellent too. Thank you. Any others that we want to add to this list? Okay, thank you for that. The only other thing that I do want to let you guys all know, and maybe you guys have already thought about this as well, but if you're not able to attend, or if you're only going to be able to attend part of the meeting, please reach out to Marisha so she understands and knows what the attendance is going to look like each week. So I think that would be important to know. Is that right, Marisha, that you'd like that ahead of time?
Yes, please, if possible. I totally understand, especially with the way things are in the world right now, that things might come up last minute, but definitely if you can reach out beforehand, that would be helpful.
Okay, so this next part that we have, Carrie is going to do. Carrie, are you ready?
Yes, thank you. I'm going to go ahead and share my screen. All right. Can everyone see my screen okay?
Yes, I can see it.
Okay, perfect. Thank you. So this is a workshop area profile. I don't know how many people are actually familiar with this type of a document, but what it really is supposed to do is it's really for any work groups or work sessions that are going to be over a period of time. It's just supposed to create alignment and ensure that everyone is on the same page as we're moving forward. Even sometimes as we're going through, monthly work sessions like this, we might need to come back to this document to say, okay, what was actually in scope, what was out of scope, what were the agreed upon objectives. So I believe Marisha sent this information out for everyone to look at prior to this meeting. So hopefully you had an opportunity, but we will also go over it right now. And then if you ever have questions or, concerns, feel free to just check in with this document if needed. So for our event description, so I'm going to read some of this verbatim. Some of it we're just going to, have conversations about. But HSD has brought the DUII Service Modernization Workgroup together to review current research on evidence-based practices to prevent DUII recidivism. And I think the last session that we had, it was really eye-opening. I learned a lot of information on the evidence-based practices. So I think that was a really great presentation to start with, to give us all a little bit of background if we didn't have that specific information. We also want to be able to review the stakeholder feedback and that has been gathered through the listening sessions and the focus groups. That is something that Marisha will be reviewing later for our agenda today. And then also we would like this group to be able to make recommendations for system improvements. So that includes reducing the DUII recidivism, ensuring health equity is included in the process and the recommendations that we're making, as well as preventing people from being killed or seriously injured in an impaired driving crash. So this work group will be meeting the third Thursday of every month for 3 hours to be able to talk about some of the issues or barriers that we're identifying in the current system that we have and be able to make some recommended solutions to improve this process moving forward. So next we'll go down and we'll talk about the current problem statement that we've identified, and it's Oregon's DUII service system was created in 1984 and no longer aligns with federal privacy or evidence-based practices to reduce DUII recidivism. So this is the problem statement that we've identified. Below are some of the issues that have been identified within the current system that we have today. I wanted to open this up for some discussion. Is this something that we can all agree upon is the problem that our group is here to solve? And if silence, I would take as agreeing on this problem.
So I'd like to make a motion to add to an objective. Can we do that?
Yeah, so our objectives are the things that we are going to work on as this work group in order to solve that current problem statement. So do you want to start talking about the objectives now, if everyone can agree that this is the problem? So Justin, are you okay with moving forward to talk about the objectives?
Yeah, I mean, I did want to talk about the objectives that you highlighted there, and I think it's worthy of an addition as well.
Oh yeah, definitely. Let's go ahead and start talking about those objectives. So the objectives that we have here, what those are supposed to do is be able to solve the problem statement that that we just identified over on the other side that we've agreed upon. So what we want to do is review and determine the current state map. So that would be the current flow of someone that is going through the DUI service system currently, and be able to look at that map at the next session and be able to incorporate any adjustments to the map. So I'm going to scroll down just for a second. Oh, Chris, do you have a question?
I do have a question.
Okay.
And maybe this is a rhetorical question right now, and so maybe it's one that we'll address later, but have we put any thought, or has OHA put any thought into, if we're shifting from a focus on diagnosed substance use disorders to a focus on DUII recidivism risk, which is a very admirable goal, how that will affect the ability for consumers to pay for treatment using the Oregon Health Plan? Has that something that's come up at all?
That's definitely part of the conversation that we would need to talk about is well, even the way it is right now, the lack of access for financial assistance for DUI education only. So that will definitely have to be part of the conversation and part of the stakeholder feedback that we heard about sustainability of the services.
Thank you, Marisha. So as we talk about the current state flow, I just want to identify that this is a high level flow. It does not get down into the weeds of the work that you guys, you all do on a daily basis. This is just the high level of if a person is going through this process, this system, this is what it would typically look like. I know that there's going to be areas in this where people will maybe stall at a certain process step, or maybe they will fall out of the process. And those are some areas that we're going to identify as specific issues or barriers to the system, and talk about what would the solutions look like if we were to, look at all of these problems. So I wanted to call out if if everyone could take a look at this process flow just to say, okay, at a high level, are we missing any process steps? And if so, bring those to the next meeting so we can have a discussion around that. You can send them to myself, Marisha, and then, as a group, we can kind of talk through the flow and what it looks like. I believe this document has been emailed to everyone to review. So that's one of our objectives, is to look at the flow and really get deep into the process steps to identify areas or gaps or breakdowns within that flow. What forms are not working? Are people stopping at a certain point? Where are those gaps within that flow? Also being able to identify, when we look at each of those process steps within that flow, what are some issues or barriers that we're identifying at every single step? And it's not only at that high level, but down into the weeds of the work that you all do on a daily basis. What specific data collection may we need to collect? What are some system enhancements that we might need to incorporate? You know, identifying those issues or barriers and making recommended solutions as we're moving forward. Those are some of the objectives that we want to hit in order to solve our current problem that we have. And I know that Justin mentioned that there might need to be an added objective. And I also want to call out, as we're having these conversations, remember to think that, you know, if something doesn't fall within these objectives that we're identifying today, they're going to get put on that parking lot that we put in our ground rules, and it will be something that we can revisit later. So we're not, so we're ensuring that we are touching on everything. We are really looking at all of the issues outside of what we're trying to accomplish, and we're not missing anything or losing sight of anything. So Justin, did you have an additional objective that you would like to add, and then we can discuss as a group?
Sure. Can you scroll up just a little bit to the first objectives there at the top of the page or middle of the page, whatever it was?
Oh,
yeah. So,
are you talking about the event description?
Correct. Yeah, the description, I guess. So, you know, I think it would be worthy to talk about the whole process improvement and process development of a new revamped DUI system.
Can you explain that a little bit more of what you're talking about?
Well, my understanding, and correct me if I'm wrong, but we're all here to talk about modernization of a DUI system within the state. So that requires analysis of the current system, deficiencies, and try to find a plan for process improvement, correct?
Yes, I think that's correct. Marisha, anything that you would add to that?
No, just that's exactly what we'll be doing through this work group.
Okay.
It's doing
So
just that.
Yeah, so it should be highlighted and bullet pointed on the description.
So I'm not sure. I maybe Justin, if you'd be willing to give some specific language recommendations, because so I'm not sure what's missing from there that doesn't say that. I mean, that we're here to make recommendations for system improvements. Do you have some language that you would like to add in?
Yeah, so maybe I'm touching on something that expands, you know, beyond of what I'm trying to say here, because I guess I am still confused on what the purpose of this is. I know that at the tail end of the group last month, you know, I asked some very specific questions. I was under the impression that we were going to be auditing or reviewing, you know, current OARs and finding deficiencies of what worked and what's not working through each entity of the DUI process. And it sounds like on the second page or third page with the flow chart or the map, that we might have that opportunity. But if we're making recommendations for changing, you know, specific OARs or processes within those OARs, I think it's worthy of identifying deficiencies that lead to process improvement. So since you have stakeholders with all these different entities involved in the DUI process, it's good to have a macro objective. So it's inclusive to include all those different types of entities. So I think the appropriate language to use would be, you know, DUI system process improvement and development. I think that would be appropriate. But if I'm using that and I'm making this recommendation, Marisha, on the premise that, you know, you bring all the stakeholders together to try to make recommendations of improving the DUI system. I don't see how we do that without first identifying what the problems and deficiencies are. So I really hope that we have the opportunity to do that.
Yeah, so that's exactly what we're going to be doing over the next several meetings. So, Carrie, do you have that the milestones document or handy, or I could share it too. I think this might help address what Justin's talking about.
I don't have it handy.
I have it. I can share it.
Oh wait, no, actually I do. It's right here.
Oh, yeah, perfect. So if you could make that a little bit bigger. Okay, yeah, okay. So so the first meeting that we had, that gave us the basis on what the evidence-based practices are, what we know works, what we know doesn't work to reduce DUI recidivism. Today, we're going to be going over the feedback that we received through the listening sessions and the focus groups that we did. And then starting next month, we're going to be taking that kind of in buckets. So looking at the screening and referral, what's working, what isn't working, what do we need to do to align with evidence-based practices, and using everyone in the room, like you're talking about, Justin, everyone's various areas of expertise to really identify where those barriers are, what those issues are. But I think what is also might be also helpful is that this isn't a rules advisory committee, so we're not going to be going step by step through the rules, because we need to identify where we want the system as a whole to be moving forward before we start digging into the rules themselves. So we will be identifying issues and areas that we need to improve, but it's not going to be like, this isn't a rules advisory committee. That will come next. I'm sure there will be multiple rules advisory committees to move forward and implement the system improvements that this committee recommends moving forward. Does that help clarify?
So if I'm understanding you right, Marisha, what you're looking for from us is to provide you feedback, to make recommendations on a system moving forward, and you're going to take that and share that with the executive director of OHA that may lead to rule changes.
Yeah, so this work group will be making recommendations on what they want to see moving forward. Those recommendations will be forwarded to OHA leadership, not me sending it to them, but they'll be go from the committee to executive leadership within behavioral health to then move forward with implementing those steps. So it's some things will be easy rule revisions that can be done right away. There may be other things that don't even require a rule revision. They may be policy that we're able to do quickly. But there are other things that may be tied to statute, where the statute has to change before we can implement new rules. So there'll be various things that are, I'm guessing, depending on the recommendations that the work group makes, there'll be various stages of implementation, things we can take care of quickly, things that will take a little bit longer, depending on what all is necessary. Like Sandy talked about, we can do this if, rather than we can't do it at all.
And I don't mean, Marisha, to monopolize the group's time, and I don't want to sound antagonistic, but I think that it's worthy of investigation, further investigation, to identify what our specific purpose is as members. And what it's sounding like to me is that this is more of an advisory panel versus a work group. So if we're calling it a modernization work group, what's the difference then of a modernization work group versus a DUI advisory group or advisory panel?
I think it as so an advisory group is usually something that's either called on by, required by statute or something like that. This isn't that formal of a group. That's why we called it a work group. But you're right. The scope is it's advising the Health Systems Division on system improvements for the DUI services system.
And just like Marisha said, as we're going through and we're organizing all of the solutions and recommendations that have been identified by this group, we are going to look at them in short-term and long-term solutions on, as the implementation plan is being developed, what can we tackle first? What's more of a tangible, easier task to implement, and what's going to take longer, like those rule changes are going to take a little bit longer, a little bit more time. And so as we look at all of the recommendations, we will bring those to leadership and organize them in a way that we can implement them and assign them to the correct people, and ensure that we are moving forward with all of the recommended solutions as long as those are approved by our leadership. And I know Tanya's been waiting, so I'll go ahead and let her speak as well.
I just had a quick question. When was that chart of information sent out? Because I'm not finding it in my email, so I was hoping to get a second copy if possible.
The profile or the one that's being shown right now?
The one that she was showing us before with the, yes,
Yeah,
that
got, sorry, I can send it to you again, Tanya. That got sent out right after the last meeting. And then it's also, there's, you can get it at the website as well, but I'll send it to you now.
Okay, thank you.
You're welcome.
Okay, so do we want to make the verbiage change here to make recommendations for system improvements?
Carrie?
Yes.
Carrie, it's Nicole, and I'm sorry, I don't think that you could see that I had my hand up.
Oh,
I just wanted to, no, that's okay. I just wanted to jump in just briefly. And I don't know if this is sort of the subtext that you were thinking, Justin. I'm not trying to put words in your mouth, but I've been with OHA for many a year, and I have certainly experienced situations where we have work groups or advisory panels, and there is feedback from the community that's like, gosh, we're telling you the same thing that we've told you over and over again, and there's no change happening. And I just want to be clear, Marisha's right? She does not get to make the decisions to just implement everything this work group says, yes, we'll do it. I don't have that authority either. But we are absolutely fully intending to implement the changes that this group recommends, right? And some of them, as Marisha said, can happen pretty quickly. They can be policy changes or rules changes. Some of them may take statutory change. I expect that some will, but this is obviously, I suppose I can't predict the future, and I don't know. I suppose it's possible that this group is going to come up with something that's so incredibly innovative that that OHA's leadership will not want to support that. But I think it's unlikely. OHA is really very dedicated to transforming the way we have historically done work, and to really empowering and engaging our partners and our communities, and to really focusing on equity. So I want to give my personal commitment and OHA's commitment that this is not a situation where we're going to listen to you and then nothing is going to happen. I want to be realistic about how fast it will happen and the processes that it has to go through, but this is I think this is an exciting opportunity, and this is not something where we're simply going to listen to you and then ask you the same thing in another year. So.
And Nicole, I appreciate that. I'm often reminded, because we do DUI work, every single day, and I'm reminded of the rule changes in 2018. And we all received, or I received, and I think it was even dated, the proposed rule changes in January. And then those rules, those sweeping changes and transformations became effective in April of 2018. At the same time, the RAC committee was changed, and the providers who signed up for the RAC were not given the appropriate meeting date and time of the new Rules Advisory Committee. And so, you're aware of that, and I brought that to your attention, and Marisha's aware of that as well. And so I guess what I'm asking is, if we're talking about substantial change here, and if we're making the commitment for this partnership with you moving forward, I guess we just need some commitment from you that that's, not going to happen again. I mean, I appreciate what you said about your change. OHA is changing the way they're doing things and the relationship that they have with stakeholders. But I'm hopeful that what comes out and what transpires out of this work group is going to be substantial, and it is going to lead to substantial change in DUI policy, because we're still seeing the consequence of some of those changes that were made in 2018, and they were done very cavalier, in my opinion.
Noted. Thanks for the feedback, Justin.
Sorry about that, Nicole. Okay, so is everyone currently okay with the verbiage that we have? Do we feel like these objectives that we've identified are going to solve the current problem that we've agreed upon? Do we need to add anything else to the objectives of this group? Okay, so we will move forward. I will take that as agreeing on the objectives that we currently have. We also are going to talk about what's in scope and what is out of scope. So I would also like the feedback on this as well. So for this group, what is in scope is the screening, referral, monitoring services currently provided by alcohol and other drug screening specialists. And they're authorized under the specific ORSs as well as the OARs that we have listed. There's also the DUII education and treatment services currently provided by DUII service providers authorized under the specific ORSs and outlined under the specific OAR. Is there anything else that we do need to add in scope here? And then what we have out of scope for this work group is the victim impact panels, criminal sanctions for DUII, and the administrative sanctions for DUII. Okay, so it seems like we're all in agreement of what is in scope and out of scope. I would also like to call out that if anyone would like an opportunity to look through this document and provide feedback during their own time, send that to either myself or Marisha. Definitely feel like you can do that, and then we'll take a look at it and we can talk about it at our next session as well. So like I said, this is the specific current state map that we've talked about. This is the process flow that we have identified. If you think that there's anything missing or a step that needs to be added, verbiage might not look correct to you, please let us know and we can work on addressing those at the next session that we have in September when we talk about the screening and referrals piece. That's all that I have to share on this specific document. We'll make sure that everyone has this document moving forward. And it looks like we are ahead of schedule. So we have a quick break on our next piece of the agenda, but since we're ahead of schedule, do we just want to go into reviewing the stakeholder feedback, Marisha?
I would support that decision, but if there's definitely would defer to other folks if folks need to stand up and stretch or go grab something to drink, or do you want to do a quick 5-minute break? Yeah. Okay, I see some folks shaking their heads. Okay, so yeah, we'll come back in about 5 minutes and dive into the stakeholder feedback.
Hi, Marisha.
Hello. How are you?
I'm good. How are you today?
Oh, good. I'm good. It's a beautiful sunshiny day outside, and I'm getting to talk about something and participate in something that I'm really passionate about. So it's a good day.
All's good in your world. I got a message that said something about you. Oh, it's just a thumbs up. Okay.
Oh. Yeah, I'm still learning all the nuances of Teams.
Yeah, this is completely new to me. But you know what was crossing my mind was that, you know, we're going through a paradigm shift when it comes to substance use abuse treatment that is moving away from trying to fix problems to trying to create recovery capital and recovery oriented systems of care. And I think as we talk about DUII recidivism rate, just like addiction is the best, or, you know, continued use of substances is the best indicator of challenges in a recovery process. I think that the use of alcohol and drugs and having an addiction is certainly a big indicator on recidivism rate. So it's definitely going to remain a part of the picture. But I love that we're taking the focus in a new way so that we could see the bigger picture, the bigger problem. So
Yeah, absolutely. A significant part of recidivism risk is the presence of a substance use disorder, for sure. All right. Well, it looks like we've got folks coming back with us. So let me try and share my screen again. Okay. Can folks see that? Okay. All right. So as you guys know, and a lot of you participated in, we had a series of 8 listening sessions through during February, and then we followed those up with some culturally specific focus groups, which some of you participated in as well. And so this is an overview of the feedback that we received throughout those sessions. And I kind of put them in buckets. So in line with the topics that we'll be covering over the next several months. So this first one here is feedback that we received regarding screening and referral. And we heard over and over from screening specialists, from participants, from providers, that the screening and referral really needs to be meaningful, not just jumping through hoops, and that folks, you know, that the people receiving the screening feel that it's useful, and also that it's useful for the courts, for the service providers. So that was super important, and that we didn't want to create additional or unnecessary barriers for folks. Also heard really loud and clear that screening and referral services, it's really important that they're supportive and welcoming, not judging or shameful, and that they're available in the person's preferred language. That is a significant barrier right now that's been identified as having services available to folks in their preferred language, not only at the time of screening, but throughout the process, and having that available, having documents, written documents as well. And that those services are culturally appropriate and trauma informed. Also heard from folks really wanting more training and ongoing support for motivational interviewing and harm reduction to help engage folks in services. You know, we all know that folks coming in to services with a DUII aren't always really happy and excited to be there. So having making sure that folks have tools to work with folks where they're at and help engage them in services is really important, and we heard that. And then also, like the presenters said, we also heard from folks that it needs to encompass more than just screening for a substance use disorder. That's an important piece, but it's not the only piece that we need to be looking for. So making sure that we're screening for other risk factors, like those criminogenic risk factors and co-occurring mental health issues that may increase recidivism risk as well, like the presenters were talking about last month. And then also, and I should say that these aren't in any type of like numbered order. So they're not prioritized or anything like that. I think if they were prioritized probably from numbers of comments, I would say that the ability to communicate openly with all members of the response team, so the courts, the treatment providers, ignition interlock device and manufacturers, to have those lines of communication open and timely is incredibly important, and a barrier right now. Also heard that the system can be quite confusing right now because the different requirements and expectations and fees vary from county to county, and not more so than county to county, even court to court. So it's confusing for the screening specialists to keep it all straight. It's confusing for the clients, and it's confusing for service providers. So an example is some courts will require that folks contact the screening specialist within 48 hours of their adjudication, and then others give them like 60 days. So it really depends on where you're at, where you got your DUI, what the expectations are, which can also really create some equity issues that we're seeing throughout the state. And also, right now there isn't a way there is no financial assistance available for the screening, and so that remains a significant barrier for folks. I often hear that it's only $150, and I remind folks that $150 is a lot of money when you don't have $150. So we heard that and really want to identify ways to help folks with that. And then also the need to be for record access. This comes into play a lot when we have folks who have delayed getting engaged in services for whatever reason, and then aren't able to access their screening or their referral. And so really needing to ensure that we have access to those records throughout the life of the case, which could, for folks who are convicted, could be up to 15 years. So looking at those record retention policies. And also hearing from our screening and referral from our ADISs and from clients is that there really needs to be some clear expectations for folks who get a DUII in Oregon, but need to complete their treatment expectations out of state. And we also have a few out of country situations, a handful of those every year. So, so having those are really important. And also often heard from folks that this is really an opportunity to help connect folks with other needed resources, and to kind of think about how we could partner with when folks are coming in for a screening to address their DUII, to look at how we might be able to address other social determinants of health. And I think the suicide risk assessment is a really good example of a step towards doing more of that. When folks come in for a DUII, they often, that's a pretty at-risk time in their lives. And so being able to, again, where it's not just jumping through hoops, making this a more meaningful process for folks. And then what we heard over and over is that this has to be sustainable. It has to be, we have to talk about the financial piece of this, right? So we have to be able to pay for the services that we expect and the quality that we expect. And so addressing that as well. Right now, the screening fee is set in statute at $150. I think that was updated from $90, which was the original fee, in like the late 90s. I'd have to double check on that though. So so identifying that there is a cost to services and identifying how do we make sure that that the screening and referral is sustainable moving forward. So I know I went through that a little quickly. When I get nervous, I talk fast, and something about Zoom meetings or Teams meetings makes me way more nervous than if we were all just sitting in a room together around a table. So I'll pause for a minute and just kind of open it up to folks. Are there pieces that are missing? Anything else that we should add to this?
You mean as far as language in this document, or?
Well, just any kind of broad, anything that we've completely missed. Is there something that you see that we were just absolutely completely missing from this list here? What we're going to do, so next month, this is the topic that we're going to be taking the deep dive into and really, like Justin was talking about earlier, identifying within the current structure of how things work, where these barriers are really affecting people, and then making some suggestions about how we can start to address that. But for now, we're just wanting to make sure that we're covering all the big topics.
I would add, Marisha, specifically the marijuana topic, because there seems to be confusion from county to county and also with the courts and providers.
Yeah, let me make a note. I can't write on my PDF, but that's addressed in the monitoring and the treatment, but I will add it to the screening and referral piece as well. Oops, sorry.
Marisha, I have a question.
Yeah.
Do you have, with this feedback that you received, do you have any data that goes along with this?
Yes and no. Data is another big topic that we're going to talk about. There are some significant barriers to accurate data collection and our ability to accurately track DUI recidivism for a lot of different reasons. So we do have some data, but not the data that we need.
Okay, that helps me a little bit.
Okay.
So on, like, for instance, the reason why I was wondering when you talked about the financial assistance, unable to pay for the screening fees, I just wondered how big that problem was, or in any of these, if we had data, sometimes we understand how big that problem is. And as we move forward, but that was the only reason why I was wondering that.
Yeah, no, unfortunately for that one, we don't have, right now, we don't have an idea of the full scope of that, is specifically for the screening fees.
This is me, Robert. I know in Multnomah County, when you say culturally appropriate, you should add the word responsive. So it should be culturally appropriate and responsive. And I can't give you a short definition for responsive. So if you ask me next month, I might give you one.
Thank you. I appreciate that.
Marisha, this is Deborah Ruiz. The person that was speaking before you asking about data regarding the evaluation fee of $150. Could she elaborate on that when she says data? I'm not sure what she means by data.
I think we're like, how many folks are in need of that type of assistance? Is that what you were thinking, Sandy?
Yes, thank you. That is exactly what I was thinking. Is sometimes when we understand, like, 75% are unable to pay, or 25%, it helps us understand how big that is and what we're actually looking at.
Well, I wouldn't have like numbers for you, but I have been evaluating since 1983. And I know that Multnomah County, when they had this contract that I have now, after 20 years, they basically went broke because they were getting, the employees, they were getting paid by the state, and they weren't collecting the 150. And they had, I hate to say they had no incentive, but they were getting paid, but they weren't collecting the 150. And after 20 years, I mean, that was it. They had to turn their contract over to private evaluators, like the other part of the state of Oregon had been doing for years. And like I said, I've been doing this since 1983, and I've worked for Marion County, and right now I do Columbia County, Beaverton Municipal since 1989. And now I took over once Multnomah County was basically, that department was basically going broke. I took over, and it's a struggle. Clients have a struggle to pay, but then the evaluators running that contract, it's a struggle. So I don't have numbers, but I can tell you that I've been doing this for many, many years, and that is a struggle, is for the clients to pay the 150. Thank God that over the years, it used to be a struggle years and years ago before OHP was with treatment. They couldn't pay for their treatment. I'm not sure when OHP kicked in and the client started getting their treatment paid, why there wasn't something addressed at that point regarding the evaluation fee. But I don't have statistics, but I can just tell you from personal experience, it's a problem, a big problem.
Thank you for sharing that. Is that Deborah that was sharing?
You're welcome.
That's the kind of information that is good to understand, because as we go through and we're looking at the issues that and the problems that we want to solve through this, we want to be sure that we're addressing a lot of those big problems that exist, so that way this will be able to flow much smoother without a lot of issues. You know what I'm saying? We just want to be able to address what we can. And especially when we know it's a large issue that needs to be addressed.
Yeah, it is. And I've always felt that I'm, one of the biggest counties with one of the largest populations, and I feel like I'm out here all by myself trying to get these people through to treatment. And I've by myself, I've tried reaching out to organizations and tapped into some of the attorney funding in Multnomah County. They have like funding that they have in recent months have started helping me with, but it's just a very small funding that somebody donated money. So we tap into that a little bit, putting these clients on payment plans. There was another organization in Multnomah County that for several years was assisting us in paying for the evaluation, but it's a minute assistance. So definitely, we really need to address that if we want to help these people become successful in getting them into treatment and getting the help that they need.
It looks like we've got a few folks with hands up, and sorry, I'm having trouble navigating my screen. So, okay, it looks like I've got Mark, Lalori, and Tanya. I don't know who was first, so I'll let you guys rock, paper, scissors, or whoever's fastest to the mute button.
Mine was
This
just
is a
real
little-
quick from a Department of Corrections standpoint, community corrections standpoint is we don't want to look at this in just a fishbowl with the 150 that they're paying for treatment, depending on the crime and whether they're on supervision or not, also includes numerous other fees that the people are required to pay in regards to supervision fees, compact fees, other things like that. So when it's just the 150, it could be 400, it could be 1,500 that's being required to pay to go through all the required treatments or required things that they have to go through. And so I know from a community correction standpoint, a bill was just passed and a lot of counties will be eliminating, if not reducing, a lot of supervision fees. And that will be coming up in the next year or so. So it's both sides. There's fees involved from community corrections, and then some are being taken out.
And I'd like to address that. That he is correct. There is a lot of additional fees, but the great assistance there is that the judges can waive those fees, where they can't touch the evaluation fee of 150 because we're basically private. And so what some of the judges do is, for instance, on the diversion court filing fee, that's $490. They can't waive the $50 victims panel, or they can't waive the 150. So what they do is, what we've come up with in Multnomah County is, when a client expresses a lot of issue, or how am I going to pay for the evaluation fee? How am I going to pay for the victims panel? Is that the judges are kind enough to take off a significant amount off the $490. And they also, on occasion, if they start treatment or get the community service done or do their jail time, they will waive the correction fees.
So these are great. These are the great things that and stuff that we're going to dive deeper into in our next meeting. And because we really want to make sure that assistance is available equitably throughout the state. And right now we just have little pockets of things that folks are able to access, and it's not consistent or available to everyone who need it. So I also, we've got LaLaurie and Tanya that also had their hands up. So LaLaurie.
So I was wondering if we could somehow, they were asking for statistics, if there is a statistic that shows that per county, what percentage of DUIs actually qualify for court-appointed attorneys. And that might be one of the closest ways that we can actually identify people that are struggling with being able to pay for those ADIS fees. I mean, that was just one way of looking at if that statistic is kept by the state.
Yeah, definitely want to look at opportunities for data sharing between different agencies. Tanya?
I was just going to add, when you had talked about if there was anything missing from this list, I think it would be really important for all the ADISs to have documents to use to address the immediate needs that are documents that are standard forms that are based on best practices, so that we're all using the same type of forms that, outside of the screening, like the suicide risk assessment, something, and having additional training to back that up and to be able to provide the service or the screenings, to all individuals, based on best practice model would be really nice.
Gotcha. I will get that added. Justin, do you have, I'm sorry, is that a new hand up or?
Yeah, I just put it up, but I don't know if someone was ahead of me.
No, I think I've got you and then Jose.
Okay, so, I know that there has been a rumor that the state has considered of either getting rid of ADISs or making those state positions. So I think that it would be worthy, maybe not now, but maybe later on, of having that conversation, because I do see a true value for the ADIS role in the state. And historically, we have had ADISs, and I think that they're grossly underpaid for the amount of work that they have to do. Going to the financial assistance piece of it, I tend to have the opposite view of what seems to be the majority of folks. What I have found is our agency is the largest private agency in the Salem-Keizer area, and we contract with over 40 different commercial insurance plans. And I will say that if we're talking about reducing recidivism, what we have witnessed from our agency is those folks who have some skin in the game and some financial responsibility tend to have lower recidivism rates than their entire program subsidized. So I would just keep that in mind as well.
Yeah, and if you have any research or evidence or data to support that, that would be great, because that contradicts what the current research is about that. So if you have anything more recent or anything like that, that would be helpful to share with the committee or the group. Jose, go ahead.
Yeah, Marisha, I made the comment in the box. So I know in Eastern Oregon, there's a Ignition Interlock program that, you know, anybody who's low income, they can qualify for that. And I've seen a lot of people benefiting from that. And quite often they come in and they ask also the question like, hey, listen, you know, I qualify for low, you know, pay low fees at the Interlock place. Can I do the same thing here with the DUI? You know, can I have my fees reduced, you know? And so there's no help for them financially, but, you know, quite often we negotiate a price with them, you know, but I think it'll be nice if we could have the indigent fund also helping these people, you know, and, you know, cover some of the cost.
For the screening
for the DUI educational piece, you know, for the treatment side.
Oh, okay. Okay. I will make a note of that. We'll get to that piece here in just a second.
Thanks.
Anything else? Any other big pieces that we're missing on the screening and referral side? And obviously this isn't written in stone. There may, you know, in for future conversations, there maybe things come up, but I just want to make sure there's no glaring misses that we have. Okay. Awesome. Okay. Well, let's
Marisha.
Oh, yeah, go ahead.
This is Mary. So when you say there's a lot of discussion here on the financial assistance, and we also get a lot of calls, you know, with those concerns. But financial assistance, you said it says a financial assistance is needed for people unable to pay the screening fees. So is that your only? Because I'm hearing a lot of, is it financial assistance is needed or just another way of funding the program? Because what I was thinking is like, why is this fee not included in the court fines? And, you know, let the court, I mean, this is a court requirement as far as statutes from what I read, you know, is that the court shall require the person to take the screening and put it in as part of those fines. I mean, because I think there's already fines that the court collects that they're distributed to other funds that do help pay for other things. Yeah. And we do that as well with licensing. You know, the license fee is not just DMV's fee. We're collecting fees for other areas and distribute those. So is it just financial assistance or finding other ways of obtaining that fee versus getting financial assistance?
Yes. So I mean, I think the real challenge for us is to really truly think outside the box, right? So if we really want to have a truly as effective as a DUI recidivism system as we possibly can, using the current evidence and research about what we know works and what doesn't, what would that look like? And that may mean that things the process doesn't look the same as it does now. I think that there's a couple different ways that could be looked at. If right now it's set up to where that fee is paid directly to the screening specialist, because those are private and independent contractors, right? So the court can't expect those folks to do that for free. So that's the way it's set up now. If that screening took place, you know, for example, like Mark was talking about, within community corrections, there would be more opportunities for fees to be waived, but then those services still have to be paid for in some way, right? So, so yes.
So our ADIS is not contracted through the court? I mean, aren't they approved by the court or approved by your agency? I mean, there is an approval purpose. It's not just anybody coming up and saying, I'm an ADIS, and now the courts are referring them to them. So, because like our funding goes to driver education, and those are also public entities, you know, and but it's distributed through transportation safety, which, you know, and that's kind of where I'm going, is where, why isn't the fee included in the court fines? That way the person doesn't have to worry. They don't see, you know, they just see this one fine with the court and not, you know, all these other piling things that they're required to do. And I mean, if a person has a choice of $150, and whether they have addiction and they haven't gone to the screening, I mean, they're going to spend it on something else versus, you know, the screening.
Well, and $150 is a lot of money when you don't have $150.
Right. And so,
I mean, if you don't have it, it might as well be $1,500 or $15,000.
Right.
So
because it sounds like the point is they're trying to get the person there, and that, you know, the fees is one of the biggest deterrents. So yeah.
100%. And I think that's part of the conversation that we have about, you know, what is our current process? What does that look like? And how can we improve that? And that fee part is a part of it. Right now, the statute requires that fee to be paid directly to the screening specialist. So any change in that would require statutory changes, which we know would, you know, so we would be looking at 2023 to implement that, or as far as getting that in front of the legislature to make that change. And when you're talking about the fees that are already collected through the court and then disseminated, there is the Intoxicated Driver Program Fund that currently pays for indigent treatment services. I don't like that term, but that's what they use in the statute. So, so that's for folks who aren't eligible for Medicaid, but are still at or below 200% of the federal poverty level. That's so increasing access to that for treatment services. The problem, though, is that that statute doesn't allow those funds to be used to pay for the screening. So right now, there are no funds that we can use to be able to direct that way that you're talking about. But we could want a recommendation that this committee could make would be for OHA to take the steps necessary to have that statutory language changed. So, so that's kind of where we are with that. There's definitely a need for it, and there's different ways that it can be addressed. And that's really what this group is going to be asked to do, is to talk through those and make some suggestions and recommendations for how to best address those. Okay. All right. So okay, so we'll go on to the monitoring. So monitoring, again, is a really vital part of an effective DUI system. And so you'll see a theme in some of these. So again, the services need to be accessible. They need to be offered in the person's preferred language. They need to be culturally appropriate and responsive, and also trauma informed. Need to be based on recidivism risk, like the presenters talked about as well. That cookie cutter supervision doesn't work for folks. There are some folks who are going to need very little supervision, and what the research tells us is that providing too much supervision actually sends them the other way, more likely to violate, those sorts of things. So we really want to make sure that low risk, low need folks aren't given more than they need. And we need to ensure that the folks who are high risk, high need have that more intensive supervision than what is currently available. Again, ability to communicate with partners is really vital. Also, the ability to intervene quickly when risky behavior is identified is really important to monitoring. Again, financial assistance and standardization around expectations, requirements, and fees. They vary from county to county, court to court. Again, expectations around folks who get a DUII in Oregon but live out of state or out of country. The talk about increasing the utilization of motivational interviewing and harm reduction to support engagement in services. So the idea of keeping people engaged, rather shifting from like the presenters talked about, that that anger-based intervention to an evidence-based intervention, really ensuring that we keep folks engaged in services, even though they may be stumbling or maybe having a relapse, that they're engaging in services, that we keep them engaged. Keep working with them using harm reduction and motivational interviewing. And also that the monitoring role has an opportunity to connect people with additional resources and needs to address other social determinants of health. And like Justin mentioned, and it heard many, many times, honestly, on a weekly, sometimes a daily basis, the need to address issues with medical marijuana patients. There are significant barriers for equitable access for those folks right now, significant barriers for to accessing treatment services when needed, and the statutes conflict with parole and probation expectations for folks with a participants in a medical marijuana program, and just the idea of the Oregon medical marijuana program in and of itself. So that is definitely something that we need to take a look at, make sure that public safety is first and foremost, and that we're also looking at folks who are using alternative medications for chronic health conditions. And also a piece that was identified, surprisingly to me, not only by the screening specialists and by the DUI service providers, but also by a few clients, is the need for monitoring to extend past treatment, and that the treatment sometimes is a limited experience, but that they may need ongoing support to help keep those changes, to help support the changes that they've made in their life. So, and that monitoring can really help with that. I think there's a lot of opportunities to use peers in this process as well that hasn't really been identified in the past, or, you know, I think there's a lot of opportunity there to help to provide support and monitoring, and to incorporate the use of peers. And again, this has to be sustainable as well. We need to talk about how, you know, if we want these services and we want intensive monitoring when we need it, that has to be paid for somehow. So how do we make sure that those services are available and supported at the level and the quality that we want them available? And so again, I will pause and take a drink and go to areas that we've missed, clarification, questions. I see Justin's raising a hand, but I also think I heard Deborah on the phone.
Yes.
Okay.
Marisha, elaborate on monitoring beyond treatment, just briefly. I lost you there.
Oh, yeah. So again, this kind of goes back to the differences in expectations from court to court and county to county. For some folks, I would say for the majority of ADISs, their responsibilities end when the client has completed treatment. So monitoring past that doesn't happen. In some areas, like in Multnomah County and Washington County, there's some more extended monitoring, but that's not the case throughout the state. And for those high risk, high need folks, that ongoing monitoring is really needed, especially when the way the system's set up right now, those high risk, high need folks, they're not driving again until they've already finished treatment. So they're not getting an ignition interlock device in until they've already finished treatment. So really the opportunity to identify if that behavior change is sticking the way the system is right now, they've already finished treatment. And so who's going to be monitoring that ignition interlock device then? Who's going to be addressing ongoing impaired driving behavior if we don't have because the majority of folks also aren't on probation. So there's really no one to monitor.
Diversion. Especially diversion people.
Well, and exactly. And so
they finished their. Go ahead.
No, I was just gonna say that's because what one court requires an ATIS to do for folks who are being monitored for diversion, it looks different than another court. And so there's really, it's very different from, and some folks get really intense supervision. Some folks get really light supervision. We haven't really found the Goldilocks part yet.
Yeah. And you know, one thing that I find, I'm not sure why this happened, but with that, the gentleman that brought up the IID machine is that they put the machine in, especially, well, diversion people is who I'm specifically talking about, is they put the machine in and they're required during their diversion year, but then they can vacate it after 6 months if they can show the court that they haven't had any negative blows within 6 months. Personally, I think that it would be more important, like you said, as far as, okay, while they're in treatment, they're getting UA'd and we're getting notified of any positive UAs. So now the machine is in while they're in treatment. They finish treatment, the machine usually comes out long before the year is up. I'd say have them put the machine in after they've completed treatment, you know, because at least that gives society, the community is safer because at least they have it for an additional 6 months after they've completed treatment. I don't like that idea, how it was developed that way.
And so this is our first intervention in where our scope ends. So OHA doesn't have any authority over the actual ignition interlock device statutes, but we do have a member of the work group, Sergeant Mike Pelkey, who unfortunately isn't here today, who would then be able to use the information and take that to address issues in the ignition interlock device realm. There's also several of us who are on the ignition interlock device advisory committee. So it's not to say that we can't have an impact in that, but we won't be specifically making recommendations to change ignition interlock device statutes, except in the pieces where they specifically intersect with our system. I know that's a little wonky how I just said that, but does it kind of make sense?
Yeah, I understand what you're saying. I totally understand. Yeah. And that was just an example. I was just trying to basically to support you in coming up with ideas so that we could have ongoing monitoring. Not necessarily want to change the IID because that is, like you said, a different scope, but there is pieces of the system that appear slightly skewed or broken, or they may have made sense to the people on the committee or when they were developing these statutes as far as the IID machine. I just meant to use that as an example that monitoring I think is a place that we can improve on.
For sure. Thank you so much.
Yeah. Marisha, I'm gonna have to take off now.
Okay.
I'm gonna sign off now, okay?
All right. Thanks, Deborah.
Thank you.
Justin, you had your hand up.
Thanks. Yeah, I think Deborah brought up some good points, and definitely the Interlock system, right now needs some improvement. And that's why there's a work group committee. One of my biggest, since we're just talking about Interlock, I wasn't even going to say this, but treatment providers very rarely get Interlock results, and the results that I've gotten are even after we've already issued a completion certificate. And that brings up to another point of, it's all for diversion claims. It's like a minimum of 90 days of treatment. Well, if you take the adjudication date to the show proof date, you have 12 months. So there's a lot of time there in between. And in some situations, we found where DUI providers have already issued that completion certificate. However, there's evidence that a person, or we gain some kind of knowledge that a person continues to use after treatment. And there's no way or mechanism, if you will, for us to rescind that already signed completion certificate. So it's just a problem. I don't have a solution for it.
Yeah, absolutely. That is for those high risk, high needs folks that where abstinence has been identified as the need. That ongoing monitoring is really, really needed and helpful. And the majority of first-time DUI folks who get a first DUI don't go on to get another DUII, but don't necessarily stop drinking or using. So that's another piece of this that we really need to take a look at moving forward is what do we need to do to reduce DUI recidivism? And abstinence isn't the only piece of that, right? Robbie, go ahead.
My question to Justin and you, can you show it in the LAC team for reporting for the results? Because that seemed like the answer that Justin was referring to, that there's a big lag time between reporting results between the machine and to the provider. And I don't know how you do that.
Yeah, the ignition interlock device, for folks who aren't super familiar with that process, the way it works right now, so we don't have real-time ignition interlock device reporting in Oregon. So the way that works is if someone gets what is called a negative report, so they've blown into the device, it's registered a 0.02 or higher, and they've been given an opportunity to rinse their mouth, wait a minute, and then test again, and it still reads at 0.02 or higher, then they call that a negative report. And that's what is supposed to be reported to the device manufacturer, the installers. They report that to the court or the court's designee, which is usually the ATIS. When the ATIS gets that report, there are administrative rules that govern their processes, require them to provide that information to the treatment provider. But if the client's no longer enrolled in treatment, if they've already completed, because their ignition interlock device has been installed after they've already completed treatment, there's a huge disconnect there. Plus then the fact that sometimes those reports are delayed, or that the reports don't ever get to the ATIS, they go straight to the court. We can't require the court to do anything with that. So there's a huge disconnect between communicating results from ignition interlock devices to the court, to the treatment providers, and to whoever is monitoring at that particular time. There's a huge disconnect in getting that information in a timely way to really truly make that an effective part of our system. It definitely has a part. I mean, right? It's stopping people from operating a motor vehicle when they're under the influence of alcohol. So it's great in that, and it's not being fully utilized as it could be to effectively promote change, ongoing behavior change for folks. Okay, Anything else on the monitoring piece that we're missing? Okay, all right. So then I'm going to go to the DUI Treatment Services, and this is all encompassing, right? So education, rehab, all of the above. Again, I'll hit the highlights of things that we've already mentioned. Wanting this to be meaningful, not just jumping through the hoops, that it shouldn't create additional barriers for folks. That it should be accessible, supportive, and welcoming, not shaming or judgmental. We really, the idea of planting seeds, right? Someone may be coming through DUI services and may not be ready for lifelong abstinence. But if you create a welcoming atmosphere and do some harm reduction, help them prevent their impaired driving behavior, they'll feel welcome to come back if and when they need additional substance use disorder services. Again, needs to be available in the person's preferred language, culturally appropriate and responsive, trauma-informed. Heard from a lot of providers who really like the manualized DUI education curriculum, specifically Change Companies and Prime for Life, and would like to see that kind of standardized throughout the system. And again, heard from folks needing to address not only substance use disorder issues, but the other criminogenic risk factors, and specifically co-occurring mental health conditions. Again, the communication piece, needing to be able to openly and effectively communicate within the parameters of 42 CFR Part 2 and HIPAA. Heard from providers and clients alike, the need for client protections to prevent unscrupulous providers from taking advantage of folks, and also heard really loud and clear from providers that they don't want to be seen as DUI mills, you know, that the services that they provide are valuable. And that they really, you know, you're there because you care. You're not, you know what I mean? And so folks really want their services to be valued. So I think those kind of go hand in hand. Again, talking about making sure that financial assistance is available for folks. The Medicaid, well, first of all, allowing Medicaid to pay for court-ordered services was a big help. Medicaid expansion was another big help, but there are still folks where paying for treatment is still a barrier. And so we need to make sure that those services are available regardless of ability to pay, and that again, they're culturally responsive and provided in their preferred language. Also heard from clinicians about ongoing workforce development and training, really wanting more training in cognitive behavioral therapy, you know, ongoing training and support in motivational interviewing and harm reduction, refresher training in DSM-5 and ASAM criteria training. I will throw out right now, if you guys haven't signed up for ASAM criteria training, send me an email. We'll get you and your staff signed up. But just that ongoing workforce development need, which I hear that 100% and really want to help address that. Talked about, again, meaningful collaboration with the Ignition Interlock device program, clear expectations for folks who live out of state or out of country, the issues facing medical marijuana program patients, increasing utilization of motivational interviewing and harm reduction, and really heard loud and clear from clinicians that they really don't want to be probation officers. They really want to be clinicians, and having the ability to have open and honest conversations about what folks are using, how often they're using it, when they're using it, can be hampered when the person thinks that if they're honest, they're either going to get their diversion revoked, they're going to go to jail, or they're going to get kicked out, or they're going to be here longer, right? So how do we make sure that folks can be honest so that we can address their true risk factors, and at the same time recognizing that driving impaired is a serious and dangerous action and crime, and public safety needs to be considered in this as well. And so making sure all of that is involved in this moving forward. And again, it has to be sustainable, right? If we want high quality, effective services, we have to pay for high quality, effective services. So how do we make sure that these services are available to the folks that need them when they need them for the appropriate length of time and in their home community? So it's like the triple aim plus one and that. Anything that I missed here? Anything that you guys would want to add? Yeah, Justin. Oh, you're muted. There we go. There we go.
I've always been curious, Marisha, as to why those clients who need higher levels of care for residential that are DUI clients, that none of their time in residential will count towards their DUI. And I understand that right now Oregon does not license residential centers for DUI, but that might be something that we want to look at and just throw out there as an idea. Because some residential treatment stints are longer than others. We've had situations where they may be doing great, and then all of a sudden they have a huge relapse towards the end of their 90 days, and they do need that higher level of care, and they're bumping against that show proof date with the court. And if their condition is severe, may require multiple extensions with the court. So I think it would throw them a bone, if you will, if some of that time within a residential program could count, or the state could work on coordinating or licensing and implementing DUI programs inside residential centers. I think that would be helpful.
Yeah, I think that's a great piece to explore, and prisons as well.
Sure. My other contention, you and I have talked about this too, are the status reports. And I continue to question that, and I understand your reasoning for confidentiality purpose, but the form that you created, it really limits the amount of communication between the provider and the ATIS, and then the ATIS and the courts. And so and it's not necessarily punitive 100% of the time. There's really good reason sometimes of why a provider may want to extend treatment beyond, for whatever reason, beyond a specific date. And we're having a lot of issues because they go to court and the judge wants more information, but we're restricted on giving the ATIS that information, so it can't be accurately relayed to the court, which may be in favor, may be in the client's benefit. So I think we need to revisit that standardized form to allow for more communication, assuming that it satisfies confidentiality requirements and that we have ROIs in place. I just think now it's very, very limited. And I've seen it actually hurt some clients in some cases. So those were my bullet points.
Yeah, no, I completely agree. I think there are some significant communication issues right now, and the way the structure's set up adds to that. The restrictions on redisclosure of substance use disorder treatment records really limits what information can be shared. Even if the DUI service provider does provide that information to the ATIS is then prevented from redisclosing it. But there are some ways around that. there's a clause when the for parties in the criminal justice system. So, for example, parole and probation doesn't have that same redisclosure restriction. And so there's some things that we could do to address that and make the communication flow much better and more timely and more meaningful communication. But yeah, the way the system works right now, there are some significant barriers to that effective communication. 100% agree on that.
I also think, I just want to add real quick that I think we should also examine the required state forms for the DUI population for the pre and post test. I think that requirement is outdated. Also, substance abuse providers exclusively are required for a mental health in order to produce a mental health declaration and also an advance directive. So I think that, I mean, an argument could be made that that's more appropriate for mental health services versus the DUI population. So I think that's something we should look at.
Oh, but those are the requirements under the general 309-019, not under the DUI, right?
Correct. Yeah. So it would apply to everybody.
Yeah. Okay. Yeah, definitely want to take a look at that stuff.
First, are we going to be looking at requirements? I mean, a lot of us do DUI treatment for other states as well. And the requirements for the state of Oregon is whether or not it's your first DUI, essentially, or your second or your seventh DUI, it's a minimum of 90 days in treatment. Whereas in other states, the people that are what they consider habitual high-risk offenders can be asked to or required to do treatment up to 18 to 24 months in the monitoring process. Is that something that has been discussed by other treatment providers as a concern?
So again, our scope is only folks who are convicted of a DUI in Oregon. That's all we have the authority to govern. So folks who get a DUI in California are required to follow the requirements of that state. So we can't affect another state's requirements.
That's not what I'm asking. I think what I'm asking is that it'd be interesting to see the states that actually have longer monitoring requirements for people that are habitual offenders. Do they have lower recidivism rates than Oregon, who has a person that, maybe on their third DUI, killed somebody, we just, and gets out and has 90 days, that the requirement is a minimum of 90 days, similar to that person who has the first time DUI, that's their requirement as well. And so I guess for me, I've always kind of questioned why it's not based on risk, and it's based on, it's, across the board, it's 90 days. Essentially, I know that we as treatment providers, we can actually, we actually base it on risk and need, but I feel like I'm somewhat of a minority in regards to that.
So, I would say the answer to your question about the data is kind of a yes and no. Because every state system is so different, it's really hard to we're comparing apples to dishwashers in most cases. And so it's really hard to say, well, this part of this component of this system resulted in these results. So there is some research around not specific to length of monitoring. We haven't seen there hasn't been any research that I'm aware of. And again, if you guys have seen something, please let me know. I I am a total nerd about that kind of stuff. I really enjoy reading research articles. So please send, I want all the research. But there hasn't been anything that has said that DUI recidivism is reduced by X length of time in monitoring or X length of time in treatment. This is partial assumption on my part, but I think the 90-day number has been in our system for a long time. And I think that was tied to the research that was done in the mid-90s that showed improvement in outcomes for folks who had been engaged in residential treatment services for at least 90 days. That 90-day point is where they really started to see increased efficacy and outcomes. I think that's where that 90-day requirement comes from, but I'm not 100% on that because again, it's been 90 days has been in there since I've been in the field, and I started in the field in 1998. So it's been around a long time. But what we do know is what the research has really shown is that when services are based on DUI recidivism risk and those individual's recidivism risk factors are addressed, that's when we see the decrease in recidivism. So for those high risk, high need folks, that means more intensive supervision and monitoring than the low risk, low need folks. But it's finding the right service at the right level for the right duration. Let's see. Let me pull up my participant list here again and see if I have other hands up. Kate, yes.
Hi, I'm gonna have to leave here in a minute, but I wanted to, for some reason, I'm not able to respond to any of the chat messages. So if it's okay, I just wanted to respond to one of the comments that was in the chat feed a little bit ago. Is that all right?
Yeah, go ahead.
Okay. So the comment was talking about the problems, and again, VIP is outside of the scope of this work group, but
Oh, we lost you. You're cutting out. Oh, I think we lost Kate. Yeah, okay. We lost her. Okay. Well, hopefully she'll be able to dial back in. Justin, we'll go to you.
Yeah, responding to the last lady's comment before Kate, I don't necessarily think we need a study to evaluate recidivism rates for longer monitoring. I actually agree with her point that if anything, it's harm reduction. So even though that 90 days may have been kind of the standard, if that was adopted back in the 90s, I think it's definitely worthy for continued discussion of how we look at either integrating a longer treatment or longer monitoring during that duration, at least through the adjudication date to show proof date. I think there's many holes in that timeline. So and there's a reason too why other states are doing it like that. And so I think her point was, if other states are doing it like that, maybe we should be looking at why they're doing it like that and why they keep continuing to do that. Or, are they looking at reducing that time? But that's something that's worthy of further investigation.
Oh, yeah, for sure. In fact, I was meeting with Julie Seitz, who she works for the National DUI Court. I would have to double check. But she was really talking, talked to her specifically about the work that they've done in Minnesota to revamp their system, and she was really excited about the work that we're doing here. She said it sounds a lot aligns really well with the work that they've done, which was encouraging to hear that we're on the right track. But she was talking about the need to really to ensure that the monitoring services, just like treatment services, are individualized to the needs of the clients, and to really ensure that so again, it's the kind of Goldilocks principle. It's not too much, it's not too little, it's just the right amount. And because providing more intense supervision for folks who don't need it we've seen repeatedly with parole and probation statistics and research is that providing intensive supervision for people who don't need it can send them the other way. And so it's finding that Goldilocks, and it's also a question of resources, right? We have a finite number of funds, of staff, of providers, and so we really want to make sure that we're focusing those intense interventions on the folks who really need it, so that we can make sure and free up spaces in our system for the folks who are so we don't have the waiting lists and the long lines that we have right now. Jose, yeah.
Just wrote it on the chat box. You know, with
oh yeah, Washington's deferred. Yeah, that's a long program. I was just talking with somebody over there. They were trying to get somebody in services in Oregon who's under a Washington deferred sentence, and really finding it difficult to do that. Yep. Yep. Okay. All right. And so then my last slide here is on data.
Hey, Marisha.
Oh, yeah.
Marisha, this is Kate. I'm back.
Oh, hi, Kate.
I'm sorry, the call just dropped. I just wanted to just real quick, so that I don't know where I dropped. So I was trying to respond. Okay, so I was trying to respond to Jose's comments about victim impact panels for Hispanic speaking like migrant workers who come here and they don't know how to read, or they don't have good computer skills. And there are definitely panels available around, different panels around the state that have interpreters for in-person panels, which of course with COVID right now, that's difficult. There are online programs there that have Hispanic speaking, so that there are options for them to be able to get the panel education, but there is a disconnect between communicating, I think, you know, what those options are and how best to help these people reach them. So even though VIP isn't necessarily part of our scope, I think it's really important to include them in the conversation, not just my panel, but all of the panels, to bring them in some way to figure out what services are they offering, what options do they have, and then making that communication available to the Hispanic speaking communities.
Definitely. And I should clarify that we definitely, when a court has required that of someone, we definitely want to be able to coordinate as much as possible. What I wanted to clarify is that we wouldn't be making any recommendations to end or change victims impact panels or anything like that.
Right.
But definitely want to coordinate with them as a member in the whole coordinated response to DUIs.
Okay.
Yeah.
That was
Yeah, Marisha, I just wanted to make a real brief comment on that. Some of these migrant workers, they come and then when they get a DUI and, you know, like they have to do the VIP online, you know, like last year. I know I've seen a lot of the DUIs diversion who got turned over to conviction because they didn't follow through with the VIP. That the courts have been granting permission to, like, if the DUI program, your DUI program has a video that is a victims impact panel, you know, they're authorizing the program to go ahead and give that, you know, education through the video so they don't have to go online, because what happens is that a lot of the migrant workers don't have a credit card. They don't have a bank account, and that is very, I mean, that's a barrier for them, because, I mean, how do they do it without a credit card? And then you have to have a credit card to get into the VIP panel if it's going to be taken online. So the judges are very, I think they're looking at that problem right now, because there have been so many turnovers with the DUI diversions that, because the language barrier, because they have no access. I mean, they just did not know how to navigate the system. So they're looking into that, and then rather than turning that diversion to conviction.
Oh, good. Yeah. Well, and I think that that's a really good piece for us to keep in mind, is that not only when we're talking about folks whose primary language is Spanish, but there's lots of folks who live in Oregon who English is not their primary language. And so making sure that those services are accessible, and that the written documentation is accessible, because this isn't just for folks whose primary language isn't English, but for folks whose primary language is English, we can't assume that they can read, and we can't assume that they're understanding what they're reading, especially with folks who've had multiple DUIs. The comorbidity of brain injury is really high. Either because of, prolonged alcohol use or risky behavior, like they're exhibiting driving impaired. And so even if we have something in writing in the primary language that they speak, we can't, we need to do more than just put something in writing, I guess is what I'm saying, and think outside of, services provided in writing, when we have folks that may not be accessible to them. So that's a really good point.
Yeah, and I think this goes back to, coordination. If anybody were to reach out to me at MAD and say, hey, we have a person in diversion who his only or her only requirement that hasn't been finished is the VIP, because they're a migrant worker and they don't have a bank account, that's something that we can figure out a solution for. Or if they can't access the online program for some reason, there are things that we can do to help facilitate that, but that's not something that we ever hear. So again, I think communication is going to be a key in helping with all of these topics.
Yeah. Another great opportunity for monitoring, to be able to step in and help connect with those resources.
Exactly.
Yeah. Thanks, Kate. I appreciate that. Anything else that we want to add to the treatment component of this? I know we really, I think the other piece to really call out in this is the need to identify the services for those low risk, low needs self-correctors versus everyone else. And when we're talking about what those services and that curriculum looks like, really distinguishing between those two groups, that they are very separate and distinct, and require very different interventions. And so I think that's an important piece that we heard in the research, and that we also heard through the listening sessions, as from clients as well. Folks that are those first time DUI, folks who've got a first DUI, who are sitting in a room with maybe someone who has been experiencing blackouts for the last 20 years. Those are very different situations. And what the research is telling us is that those low risk, low need folks, their outcomes are their positive outcomes are decreased when those two groups when those populations are mixed. And so really making sure that those services are separate and distinct. And again, that goes back into making sure that services are sustainable, right? So we know that you have to run a group, to be cost effective to run a group, it can't be for one person or for two people, right? So making sure that that we're talking about those pieces moving forward. So then the last slide here is about data. And what we really heard loud and clear, and I am is like a core belief of mine, is that if I'm not going to use it, I don't want to ask you guys for it, right? The data shouldn't be busy work. It should be meaningful. If we're collecting it, we need to use it, and we need to make sure that our data is accurate. So, so first and foremost, making sure that the data that we collect is meaningful and useful. But there were a few things that I heard from providers that would be especially helpful, and from the screening specialists. One of the areas right now is really being able to identify who truly has a first DUI versus folks who have had multiple DUIs. And right now it's difficult to do that. We can't rely just on the legal status, so conviction or diversion. That won't, because we could have folks who got a DUI or equivalent charge in another state, but it wasn't equivalent enough for our statutes to recognize it. So it is positive. Plus, then there's a time limit, and I always get it mixed up. I can't remember if it's 10 or 15 years, but so it's possible for you to have a previous DUI, go 10 or 15 years plus 1 day down the road, get another DUI and be eligible for diversion again. So we can't rely on their legal status to identify if they're in diversion, this means this is their first DUI. Same thing is applicable on the conviction side. There are folks who just choose not to participate in diversion and would rather take the conviction. There are also folks who have a CDL who can't accept a diversion. There's some federal requirements around that. So we can't assume that someone who's convicted necessarily has previous DUIs. Usually that's what it means, but we can't just look at diversion or conviction and say, oh, these are first offenders. These are, oh, sorry, I really try not to use that term. These are people with the first DUI, and these are folks who've had more than one. So that's a really big piece, is being able to accurately identify that. Sorry, Lisa, you look like you're about to ask a question. No? Okay. And then also being able to accurately track DUI recidivism rates at the, the state level and the county level. Right now, again, it's mostly about adjudication status, so diversion or conviction. We can't really say that, because we had more convictions this year, that means we had more folks with repeat DUIs. And then also need to accurately track the screening, referral, monitoring, and treatment for quality improvement and process monitoring, and to be able to accurately identify where health inequities exist and to be able to address those. Right now, we aren't able to follow someone through the system. And what I mean by that is we don't have a coordinated data system to where we could say, okay, these are the people that were arrested for DUI this year. These are the folks that were adjudicated. These are the folks that were screened, entered treatment, completed treatment. We don't have a way to follow folks through that system because of coordination through court data, LEDS data, law enforcement data, and then treatment data. They don't talk. And so we don't have a really good way to accurately identify recidivism and identify what services are working for what group of folks within our own system. So moving forward, we really need to be able to have a good data collection system to really be able to identify that our services are, that what we're doing is making an impact and actually reducing DUI recidivism. And I'm sure that there will be a lot more discussion about that as we go, and as we talk about, get into the details of how the current system works. We'll be able to identify where those opportunities for better data collection data reporting can go. But so are there other areas that folks want to throw out that that we want to talk about when it comes to data or performance monitoring? Justin, yeah, go ahead.
Yeah, I've been in the field long enough where I remember the days of CPMS, and then when MOTS rolled out, you know, MOTS is extremely cumbersome. It's a large expense. There's a lot of EMRs out there that aren't integrated. And I think that that's worthy of re-examining that whole process and coming up with a better way, because right now it's just a big burden for providers. That's, I know you want to respond to it, so go ahead, because I have a second point. But
no, I am agreeing 100%. I did just get an update on that today, though. So there was an RFP for the MOTS replacement project that was released. They're reviewing proposals right now, so there is movement to make significant changes and adjustments and make our data collection system more meaningful and useful. So.
Well, that's encouraging. I don't think there's
no promise on when that's going to happen, though.
So my second one is kind of far out. Are you ready?
Yeah.
So, you know, I've been thinking about this for a while, and I hate the idea that we're still using carbon copy for DUI certificates. I think it's extremely antiquated. I know that there was some slight improvement a few years ago where we had to send the list to Mary, and then we get a new stack of these, and then we had to send one copy to the client, one copy to the ATIS, blah, blah, blah. What I would propose, and this is just one idea, is that I don't know if you're familiar with how MacBo changed their system when it comes to the credentialing. And so you log in to the site on the, I forget what it's called, Certime, and they have different steps. And as you complete different steps, you upload different documents to that. And so it kind of gives you a timeline of where you are at towards your completion or recertification. My proposal would be for the state to implement something like that, according that was in accordance with confidentiality laws, assuming we had ROIs for those entities, or only those entities would have access to the site. But then it would provide kind of the first step where they go to court, and then the court uploads, you know, the court documents. Then they go to the ATIS. The ATIS referral can upload their referral. Then it's sent to the treatment provider, and we can upload our status reports, upload the assessment, whatever, you know, we need to upload. Track to the VIP panel would be included in there. So then at that point, the treatment provider or the ATIS wouldn't necessarily have to be responsible for quote unquote paperwork. Right. They would still have, you know, have a valuable part of the process, but all the paperwork would already be there for the court.
Yeah, I think that's a great idea to explore. And I mean, just the idea of having all of the information in one place. Especially for like record retention purposes, for somebody, you know, who for some reason they need another copy of their certificate 7 years down the road or whatever. Mary, Garcia, and I have been working over the last year to get the actual DUI treatment completion certificate, that 4-part form, into an electronic format so that we didn't have those carbon copy for all that kind of stuff. It has become, and to be just 100% honest, COVID has complicated that. Like, our IT resources are maxed to complete capacity, and totally understandable that this project is not high on the priority right now. But Justin, you and I are right there with trying to make that a more streamlined, easier process for tracking purposes and just everybody involved. It could be, we're past the quadruplicate carbonless paper form now. We're in 2021. We can figure out something a little easier. So yeah, but I love that idea of having a centralized system where it's not just the certificate, it's the whole process. So definitely think that's worth exploring.
You could even integrate MOTS and whatever data information, you know, you needed to be entered in that too.
Yeah. Yeah, great idea. Perfect example of thinking outside the box too. All right. So that's where we are with the stakeholder feedback. Again, we're coming to the end of a meeting with a lot of information. I feel like at some point I hope we're going to be able to have like USB ports that we can like download our brain into a little bit, because my brain's feeling a little full right now. But so I think where we're at now is to, like I said, next month we're really going to dive into is specifically talking about screening and referral. What do we want that system to, what do we want that to look like? What are the barriers right now, and how get into the details of how we can start making changes to that, making it more effective for our clients, more meaningful for them, and more impactful. So let me pull up the agenda. I know we are ahead of time, which is always nice in meetings.
I think you have one other hand up, but I can't see who it is.
Yes, Jose, sorry, do you have your hand up? Nope, that an old one, okay. So I'm gonna go ahead and actually let me run through my participant list again, just to make sure I didn't miss anybody. Okay, all right, so I'm gonna turn that back over to Sandy and Carrie then, just to wrap us up and get us ready for the deep dive next month.
Okay, before I get into that, I just wanted to mention on the data part of it, how important data can be in understanding where you are currently, and as you guys make changes or suggest changes, and then as those get implemented, then being able to look at them and say, did we make a difference? So that's kind of why it's really good to understand what data you can gather and have, and then be able to look at what impact it has made. So just a plug on the data part there. Okay, so for the next meeting, so I think that Marisha, you've already mentioned that we're going to be doing the screening and the referral, and that's really going more into the depth of that and coming up with your recommendations. We'll be sending out a agenda, so you guys will see a little bit more about how we're going to align that and what our plan is for the hours spent, so that way you can be prepared. And then also, Carrie had mentioned, take a look at that flow map too, just to understand the flow. It's really good to be able to look at the full picture, even though we're going to take chunks of it and work on chunks. So take a look at that and then let us know if there's anything that you see missing. Marissa, anything else that I should add before we wrap up here? Are you talking?
I'm muted. Just a reminder that we'll get this, the recording of this meeting posted on our website as soon as possible, and I'll send an email out to everybody letting you know that it's up if you want to reference back to this. And then, like Sandy said, we'll send the agenda out at least a week prior to the next meeting, and for the work group members, it'll the agenda will also be attached to your meeting, your team's meeting invite, so you'll have that there as well.
And Marisha, just to circle back, as Jen Psaki would say, if the soonest that you can look into that, the new governor's order, and if y'all can provide anything to providers, that would be super helpful, because it could impact my staff significantly.
Yeah, for sure. I'm going to follow up with Nicole as soon as we finish up here.
Okay, I think that's it. If there's anything else that you guys need or would like to reach out to us, please just send us an email and let us know, and we can address for the next time. Thank you.
Thanks, everybody. I appreciate you being here
Thank
today.
you.
The feedback was great.
Thank you.
Bye.
Thanks, everyone.
Thank you so much. Bye, everyone.